Okay, so we ended the last video talking a little bit about how when a patient has high lipase, it's going to potentially bind up that calcium and make it unusable temporarily until the lipase levels go back down. And so you might see a full picture of all signs and symptoms that you're used to with hypocalcemia. I had mentioned that paresthesia that the patient might feel around their lips, their fingers, their toes, that numbness, that tingling kind of sensation. They can also have any form of tetany, so that muscle tightening, those spasms. They could even have those signs of hyper reflexes. So, like, check for a Schwastic, right? So, just thinking of things you can screen for when it comes to low calcium. Then really, and this is the key, this is key when it comes to pancreatitis, since a major cause of pancreatitis is going to be gallstones, we have to do some imaging. Every patient who is considered to have pancreatitis, we have to either rule in gallstone as a cause or rule it out. So every patient being worked up for pancreatitis will have imaging. And that can be done in the form of x-ray, CT scan, ultrasound, preference of the ordering provider, or preference of what's available right at that facility. So make sure that you expect that imaging is going to be done. And when you're talking to the patient about what we're doing, sometimes pancreatitis can be caused by a gallstone, and we're checking to see if that's what's going on with your story here. All right, clicking over to what are we going to do about it, right? What are evidence-based nursing interventions to take care of a patient with pancreatitis? First of all, this is severe unrelenting pain. So analgesics, right? Because it's severe pain. And what type of pain medication do we give for that severe pain? Obviously, we're talking opioids, okay? So plan to be administering those to this patient. Also, we can recommend side-lying fetal position for pain relief, okay? So laying on their side with their knees kind of up into their abdomen a little bit, tucked up, that side-lying fetal position tends to give patients with pancreatitis a decent amount of relief. So make sure you realize that is an evidence-based intervention that we can support our patients in their pain management, okay? Antiemetics, because nausea and vomiting might be occurring with these patients, so we want them to not feel miserable, and we certainly want to avoid any potential aspiration or anything that can happen with vomiting. We make these patients NPO. They should not be eating or drinking anything, and I'm going to ask you why. We want to rest the pancreas, right? Pancreatitis is that inflamed, angry pancreas, and the only way for it to heal is for it to get a rest, a little vacation from the jobs that it's supposed to do. And one of the big jobs that it does is it releases pancreatic enzymes whenever there's anything, any type of food or drink that is going to be coming through the intestine. So keeping that patient NPO is going to be key, okay? So expect that for every pancreatitis patient. Then we're going to take it even more one step further, okay? We're going to place this patient on nasogastric suction, and I'll tell you the why on this one. Even when the patient's NPO, the stomach is still creating gastric juices, gastric acids and such, and passing that through into the intestine. And we do not want that pancreas to have to start working for anything, right? So we don't even want gastric juices created by the stomach to be passing substances onto that intestine. We want it completely empty. So we are going to connect the patient to nasogastric tube and then to wall suction in order to keep the stomach empty so that we can give the pancreas its rest, okay? Now, obviously, if we've got the patient NPO and on nasogastric suction, the last one should make sense, right? Everybody has to have an input, right? Where are the fluids coming from? I hope that you guys are as obsessed with this as I need you to be at this point, right? We started this semester talking about fluid imbalances, and I want you to be very obsessed with where is my patient's intake coming from. If they're NPO and on nasogastric suction, of course, they have to have IV fluids continuously infusing. And that's usually going to be a normal saline solution. It certainly also could be a D5W, right? Just to kind of pop the patient a little bit of sugar, as their NPO for any kind of prolonged time. Also, kind of in those IV fluids, since we're doing nasogastric suction, what's something that your patient might be losing through nasogastric suction? electrolyte juices, right? And especially potassium. So we might actually have to do a little potassium replacement. Just if your patient's on nasogastric suction because they have pancreatitis, we're going to keep an eye on that patient's potassium because we're suctioning it out through that tube. Then I want you to consider, we already talked about how high lipase levels can bind up that calcium. And so if your patient is hypocalcemic, there's a chance they might replace with calcium if the symptoms are too severe. This gets complicated because the patient technically does have enough calcium. It's just temporarily bound up because of the high lipase. So we want to get into a situation where we're very careful, where when the lipase levels go back down, we don't want the patient to have hypercalcemia. So it's not super common to be giving your patient calcium, but if those symptoms are dangerous enough, they might. All right, ongoing monitoring of those pancreatic enzymes. I mentioned this earlier in the last video. We're going to keep an eye on those pancreatic enzymes, and they hopefully should be trending down. We're going to educate about the underlying issue, right? If the underlying issue is related to alcohol, then chronic alcohol use, then we really need to connect that patient to support. And we want to do this in a very supportive measure and non-judgmental measure, and be very cautious of that because the way that you send messages to this patient, they're going to know the difference between caring and judging, right? And just box checking, if I can be just completely frank, right? Oh, here's some resources, kind of a thing, versus genuine caring and hooking them up with resources. Obviously, it's always a great idea to get social work involved because we are not experts at knowing all of the resources in the community for alcohol abuse and support for alcohol abuse. And we want to make sure this patient is connected to everything. So it would be great. Also, if the underlying cause was a gallstone, we need to teach the patient a diet that's going to prevent gallstone recurrence. Well, what kind of diet causes gallstones? It could either be a super high fat diet, so we want to decrease their fat intake, right? Or it could be long-term fasting, and we would want to screen for that and address that and find solutions for that if that's the case, okay? So that's it, really, though. Just kind of simple. How do we take care of a patient who has pancreatitis? We manage the pain and the symptoms, and then we rest the pancreas. And we do that by making them NPO. Keep that stomach empty. Keep that stomach empty. So NPO and nasogastric suction, so that there's nothing going into the intestine that's going to make that pancreas have to do its job. It's on vacation, okay? And then understand that a lot of the supportive care that we provide can cause its own problems. For example, nasogastric suction. So make sure that you're monitoring the patient and fixing all those things so that our nursing interventions are not causing more problems for this very uncomfortable patient. We'd like to send them home with this problem resolved and on our way to not having a likely recurrence of it. Okay, complications. As with almost everything that we've talked about so far in the abdominal cavity, it can hemorrhage, which can lead to hemorrhagic shock. And you know what to screen for that already, right? And then it can become infected and cause sepsis and septic shock. And you know what to screen for that. So all of these organs can progress to infection and septic shock. And all of these organs can progress to hemorrhage. And that bleed can actually cause enough blood loss, can cause that hypovolemic shock. And you know all the things, right, to screen for all of that. Okay, so I'd like for you to just kind of give a 1-minute summary to a patient with pancreatitis, right? This is what they think you might have because of these signs and symptoms, right? This is the testing that we're going to send you for. This is what, walk them through the whole thing and the treatment and the whole spiel, okay? Make sure that you guys feel confident that you genuinely understand this particular disorder and how we as nurses are going to take care of it. I'll tell you, this is not one that is rare. Pancreatitis is a common occurrence. On a med-surg unit, you're going to see an awful lot of it. And so please make sure that you guys feel confident in how to care for this patient.